Then coming to the other application, which is very, very exciting and I think very useful for primary healthcare physicians. And this is, as you can see, a smartphone sized device with, this is the smartphone sized device, and this is the connection to the transducer. So the transducer is placed on the chest, and it will show on this cell phone like device, and you can see different parts, and you can basically sort of use this particular, you can even digitally store it for showing it to somebody else. So at the bedside of the patient, even at home, if you make home visits, you can take this device, do the echo, record it, and you can give him some answer. At least ventricular function, some gross structural defects can be picked up very easily. So as I said, this is some of the most exciting advance over the past 2 decades. A handheld ultrasound or echo device, which uses battery instead of continuous line, and which uses battery, and which produces a reasonably good image quality, which may not be equal to the regular echo, but it's very comparable to it. So what is the benefit? It can allow quick decision making. It is easy to use. It is readily available. Any physician who makes home visits can buy it, and it's not that costly. And they can transport it and take it direct to the patient where they want to do this test. So of course it will require a little bit of training, and that is the whole idea of our module, that we will train you so that you can do those things. And it, of course, the interpretation will require a certain proficiency to make the interpretation, but broadly it can be used as a point of care echo machine by any novice examiner, and it is nearly comparable to that of that done by the cardiologist. So that is the beauty, that at even at ground level, or at the first primary healthcare level, you can take this device and use it on anybody and produce a image quality which is as good as a regular echocardiography machine, nearly as good. Now coming to the last part, uh, you have understood what are the types of echoes. Most important echo is the standard two transthoracic echo, and transthoracic echo is done by I have shown you the figure, you can see these are the points where transthoracic echo is placed, and this is the suprasternal, this is the uh, parasternal, this is the subxiphoid, and this is the apical view. So this is the apical. Once you apply the transducer probe here, you get a apical view. Once you apply it here, just below the sternum, inside the gap here, this is the substernal view, or subcostal view, and this one is, as I said, apical view, this one is parasternal view, and this one is suprasternal view. So these are the different places where you would place your probe to look at heart at different views. So this is the way you will place, and so again, if you look, this is the parasternal view, this is the parasternal view, this is the apical view, this is the subcostal view, and this is the suprasternal view. This is the suprasternal view. You place it in the suprasternal node. In the subcostal view, you place it in the substernal xiphoid area, and on apical view, you place it at the apex, and parasternal view, you just place it on the side of the sternum. And if you look at these views, this is how it will look. So different views will show different. This is the parasternal, this is the subcost, this is the long axis, this is short axis, and this is the apical 5-chamber view. So different transthoracic views are here, and this is what it will look, and we will have a special module on this, so that will very clearly show you all the differences. Coming to modes of echo. So what are the various modes in which echo is recorded? So one is the basic mode called the A mode, which is a single line. Then there is B mode, which is repetitive scan lines. Then there is an M mode, which is these lines which move with time. So it is called M mode or motion mode, where movement of the heart can be obtained in time motion, and you can basically do dynamic cardiac images. And then there is a 2D, where it is multiple B modes which are aligned at an appropriate anatomic location. So when you take many B mode lines, connect them with each other in a wedge shaped manner, then obtain the spatial information from it, then it is called a 2D echo. So basically you have to understand, commonly what we use is M mode echo, which is the movement of echo with time, or those same structures will move with time, and so you can see in different parts of systole or diastole how these structures are moving. So you can record and you can basically align it with the ECG, so you will know what is the position of a given structure at systole, what is the position of a given structure at diastole, and then again systole, diastole. So excuse me, along the time you can measure. So it is a M mode or motion mode. And here is the example to make it more clear. This is, as you can see, a transducer applied on the chest wall. Below lies the heart, and basically heart and great vessels. And if you do a mode, what you will see is just when the transducer is like this, it will show you a single line. In B mode, you will see these collections, but in M mode you can see, so for example, if this is valve, you can see how the valve is moving on time, when valve is closing, when valve is opening, and then closing, opening, something like this. So basically M mode will show you movement of the valves also, in case you want to look at it, or at different parts of the heart, how they are moving with time, that you can see with M mode. So what are the different types of echo? Again, just to tell you what are the various modes that are used today. One is two-dimensional mode, which I already showed you. This is I will actually show you the two-dimensional mode. And then there is a three-dimensional mode. Then there is a Doppler echocardiogram, where the signals, Doppler signals, remember I told you, when the sound waves hit and they get reflected. But the if the subject is moving towards you, then the kind of image produced is different, but if it is moving away from you, it is different. So that is what is put with Doppler echocardiogram. And color flow imaging is one type of Doppler, one application of Doppler cardiogram only. So now to show you clearly, the topmost is the M mode. You can see M mode, and you can see different parts moving, and you can possibly see the cavity. This is the LV cavity. So you can see in systole the walls are coming closer, in diastole, in systole they are coming closer, in diastole they are moving away, in diastole they are moving away. So this is how it happens. So systole, diastole, so you can see, actually calculate what is the area in systole, what is the area in diastole. You can actually calculate the ejection fraction through it. So this is how it will help you M mode. You can also look at mitral valve apparatus, how it is moving, aortic valve, how it is opening, closing, all those things you can make out. But this is the collection of B mode to form the 2D imaging. So this part is the 2D imaging, and you can see different cavities, chambers that you can see. You can see the left ventricle, you can see the mitral valve, you can see the left atrium, you can see the right ventricle, the tricuspid valve, and the right atrium. So all these structures you can very nicely see here in this 2D echocardiography. The whole structure of the heart can be seen, and you can see how this septum is being pushed towards the left ventricular cavity. So you can make some observations also. The third type of echocardiography is the pulse Doppler. So when you put the echocardiography and you take the Doppler images, then the things that are moving towards you and things that are moving away from you will come out. So when things move towards the probe, you will get a positive deflection, but when things move away from the probe, you will get a negative deflection. So you can get a positive deflection, you can get a negative deflection, and that's why you can decide what is the velocity of the blood moving away from a structure or moving towards the structure. So for example, if you want to measure the aortic regurgitation, then you see that the jet will come towards the probe in a given speed. But if you want to look at aortic stenosis, then it will move away. The more the aortic stenosis, more thing will be there. So normally, if we take it at mitral valve level, so the positive thing will be, if lot of positive thing is coming, then it will be showing mitral stenosis, and if it will be moving in this direction, then it will be mitral regurgitation. On the other hand, if you are looking at aortic valve, then because aortic valve is differently situated, things moving in the upwards direction will be aortic regurgitation, and things moving in downward direction will be aortic stenosis. So depending on where the structure is located, the blood coming is either towards you or away from you, and that determines what kind of flow is there, and that determines the uh, whether it is a stenotic or a regurgitant lesion. Likewise, this is the last. Here what you can do, instead of showing these pressure traces, you can give a color code. So things which are moving towards you will look blue, and things which are moving away from you look red. And also have to remember that you can use this particular thing to find out broadly whether there is a aortic regurgitation or mitral regurgitation. So anything coming here will show you mitral regurgitation. Anything going up will show you mitral stenosis, but going inside the left atrial cavity will show you mitral regurgitation. So color, if it is moving inside the LV cavity, in the LA cavity, will be mitral regurgitation, but color, if it is moving in the LV cavity, then it could be mitral stenosis, and I will show you exact things. Then the second type, as I said, was M-mode echo. M-mode echocardiogram is not a picture, but it is rather a diagram which shows you the position of various structures. And here, this is at the level of mitral valve, and what it can show you is how the valve is moving, and it can show you many things. And how the valve is moving, you can decide whether it is a stenotic valve or a regurgitant valve, or what is the problem, what is the also you can calculate various areas. So where is it useful today? When you want to see the motion and thickness of ventricular walls, because I think that is more important. Even more than valve, what you can show is that this is the thickness. So you can calculate the thickness, and you can measure the ventricular area. So this thing you can measure differently, and so you can look at the thickness, you can look at size of the chamber, and you can look at opening and closure of valves as well. And you can, based on the opening and closing of valve, you can decide whether the valve is normal, whether it is stenotic, or whether it is regurgitant. So all this information is possible. This is, for example, mitral valve, and you can see how mitral valve is moving during diastole. It opens up like this, and during systole it closes, and this is then pre-systolic. This is the just before opening of the mitral valve. So again, this is the way. So this is a pre-systolic contraction. So you can see very nicely. So this is the mitral valve, and you can see different parts of the shape of the mitral valve. And this is how the aortic valve opens. So when there is ejection, aortic valve opens. So this is the opening, and during diastole, the aortic valve closes. So here it closes. So you can see the opening and opening of the valve. This is opening, and this is closing. Here, this is the opening of the valve, and this is closing of the valve. So both you can look very nicely on this 2D echo if you want to look. Now coming to the I meant M mode echo, not 2D echo, M mode echo. Now coming to the 2D echo, this is actually you see the structure very nicely. So here what you see is this is the this is the LA. You can see this is the mitral valve. This is LV. So as you can see, this is the ventricle. This is the left ventricle. This is the left atrium. This is the mitral valve. This is the aortic valve. Left ventricle opening into the aortic valve into the aorta, and this will be right side of the heart. So you can very nicely see different structures in the heart, and basically what it is done in a it is in a wide spectrum. It produces the ultrasound images in a wide arc about 90-degree, and you can pick up whatever structure you want to see, and it is a combination of reflected ultrasound waves which gives you this particular picture. Then coming to the third type of echo, that is the Doppler echo. Doppler echo, if you remember, I told you in the history, Doppler detected this, is the method for detecting the direction and velocity of moving blood. So basically, if it is moving towards you, it will come out as a positive, thing. If it is moving away from you, it will come out as negative, or towards you or the transducer. So depending on the direction, this Doppler can very easily pick up the direction and also the velocity. The more the amplitude, the more the velocity. So if the amplitude is only this, the velocity is less. But if amplitude is this, then velocity is very high. So it can pick both the direction and velocity of the wave. And there are certain formulas, and I will not go into it. Pulse wave is produced when the transducer gives us pulses of waves. So it gives one wave, waits for it to penetrate deep inside the heart, get reflected, the transducer picks it up again, and then it gives the next pulse. So that is pulsed wave Doppler, where repeated pulses of the ultrasonic waves are generated, and they go to the structure of interest, get reflected from the structure of interest, picked up by the transducer, and only after that the next wave comes. So that is the pulse wave Doppler. On the other hand, continuous wave Doppler is a situation where continuous waves are generated and they are picked up continuously. So continuous are generated and picked up continuously. So here the basically you can color code it also. A continuous wave you can color code it. Blue, whenever there is a red, the flow is towards you, and whenever there is blue, the flow is away from the transducer. So, and whenever the color comes, it means that already the flow is turbulent. So blue is away from you and red is towards you. Now coming to again how the color Doppler codes. Red is towards the transducer, red is towards the transducer, blue is away from transducer, and green, when it happens, it means that there is a turbulent flow. Both are mixing and it shows you that there is a turbulent flow and therefore something abnormal. Normally flow should be laminar, but when it is not laminal, when it is turbulent, because maybe stenosis or maybe regurgitation, then the code will become green. So whenever there is green, will directly tell you that there is a problem, and you have to find out whether it is a regurgitation or it is a stenosis. So this is it, and the simple formula is BART, blue away, red towards. So always remember blue away, red towards, which is the formula, which is BART. Now coming to again between pulse and continuous Doppler. In pulse, as you can see, pulses are generated. This is one pulse, then waited, then another pulse, then waiting, then another pulse. Whereas in continuous, everything is continuous like this. So this is continuous, and this is pulse. So this is pulse Doppler, this is continuous Doppler. Where pulses are generated is pulse, and where this is generated is continuous. Now, what is the advantage of Doppler? The 2D echocardiography shows you the structure. So it shows you what tissue, what anatomy, what structure, uh, and the alignment is perpendicular. Means if it is like this, you apply like this, and the transducer frequency is high. Whereas if you look at Doppler, it actually not looks at the structure, but it looks at the flow. So it will look at the flow, it will look at physiology, it will be more of function rather than structure. And the here you get a better picture when you align the probe parallel to the structure. So if you align parallel to the structure, you get a better picture. Here in 2D, if you align perpendicular to the structure, you get a better picture. Here you have to apply parallel to the structure, and then you will get a good picture. And here the transducer frequency is low. So this is the difference between the 2D and Doppler. Now, what are the indications of echo? We have been discussing again and again. They can be structural or they can be hemodynamic. In the structure, you can look at various types of structure. You could look at coming from outside in, you could look at pericardium, you could look at cavities, whether it is left atrial cavity, left ventricular cavity, right atrial cavity, right ventricular cavity, and structures inside the cavity like thrombus, or you can look at the walls of the cavity. You can also look at the walls of the cavity, whether they are moving normally or they have wall motion abnormalities, or whether they are thick, which means they have, if right ventricle is cavity lining is thick, then it is right ventricular hypertrophy. If left ventricular muscle mass is thick, it is left ventricular hypertrophy. Then also it can look at uh, different valves. When we come inside, it can look at great vessels, and it can diagnose many diseases like congenital heart disease, traumatic heart disease, hypertension, lung diseases, arrhythmias, and even neurological diseases. So this is the usefulness of structural imaging. On the other hand, there is another type of imaging called hemodynamic imaging, where you look at the function. So you look at the valve function, whether there is a normal valve, or there is a stenosis in valve, or there is regurgitation in valve. Also, you look at the blood flow, calculate the total cardiac output. You can look at the ejection fraction, whether it is systolic or diastolic ejection fraction. But of course, while the risks of echocardiogram are very, very low, practically nil, some people can have discomfort because you applied pressure on the chest wall, especially thin chest people, older people, you might face this problem. If somebody has some skin problem, then they can have hyperesthesias where you apply the probe. If you have to do contrast echo, sometimes you give contrast, there can be allergic reactions. Lying down for a long time for a echo, you can have backache, some people can have headache. If you inject something, you can even have rash. So these are some of the things that are possible. But with transthoracic echo, these risks are minimal, only those are listed. But transesophageal echo may have some more problems. There could be a problem because you have to insert the tube inside the throat into the esophagus. They may develop sore throat. They could have struggle swallowing. They may have change in voice. They can have lung or throat muscle spasms. They can have even a small amount of bleeding. There, you could injure the tooth, gum, or lip by when you pass the big probe. There could be tear in esophagus, more serious. There can be change in heart rhythm. Suddenly, patient can develop atrial fibrillation, and then can be uneasiness due to medicines which are taken during the test. Likewise, when you do stress echo, there are also some problems. There could be hot feeling or flushing. There could be low or high blood pressure. If you do drug stress testing, there could be allergic reaction. And very rarely, if you exercise the heart too much, they could develop heart attack also. So you have to be a bit careful. Like all the stress tests, you cannot stress them too much. Now coming to echocardiography, before echocardiography, what are the preparations that to be done? On the day of test, most patients are allowed to eat and drink as they normally would. But if transesophageal echo is planned, because you have to put the probe inside the esophagus, the food and drink are avoided for a few hours before the test. Medications are checked, and to see if they are not going to cause any problem, then patient will undress waist up and put on a hospital gown, and then an echo technician will put electrodes on the chest so that you can time the echo events. During the echo, person generally lies on the left side, tilted towards the left side of the exam table, and basically the probe will be put on the chest wall. Before putting the probe, they will generally apply a small amount of, we will apply a small amount of gel to make a clearer image, and to allow the sound waves and Doppler signals to travel appropriately. So that is why the gel will be applied. Then ultrasound probe is applied in different parts of the chest. I already told you where to apply those probes, and they will produce a, idea is to put them at a place which will produce a high resolution non-obstructive view, and directly at the beating heart or the vasculature that you want to see. Then during the procedure, the echocardiographically will change the position many times. In subdefault view, you will have to lie straight on the table. The patient will lie straight and flat, but will turn on the little bit on the left side for most of the views. Generally, they don't feel anything except they can feel some pressure. Normally, the test take up to 40 minutes of time. Normally, unless you are doing some complicated thing. But transesophageal echo is a bit more complicated. Patient has to be prepared beforehand, and the certain history has to be taken, whether patient is having hiatalania, is having any problem swallowing, is having any cancer. Because if there is a esophageal cancer and you put the probe, it displaces the cancer and it spreads it will be more problem. Here the patient will remain nothing by mouth for 6 hours, and then but other medications generally they take. During the TE, the nurse will put an IV line also, and where they can give some medicines, and same ECGs will be put, and patient might be given some mild sedative also, so that he can cooperate during the procedure. During the procedure, the echo team or the echocardiographer will pass the echo probe into the mouth, down the throat, into the esophagus. But since the breathing apparatus is all clear, there is no problem in breathing, only in the esophagus. Then patient will be asked to swallow the probe, so he has to cooperate a little bit. It is a bit uncomfortable, but if the patient is able to do it, then probe will go into the esophagus and it is practically painless. It again takes about 30 minutes, but patient is not sent immediately afterwards. 30 minutes patient is observed, and patient is kept nothing by mouth until the effect of sedative wears off. After the TE, as I said, basically they have to be observed for about an hour, but after that they can resume their normal activities. Certain contraindications for transesophageal echo: severe dysphagia, esophageal stricture, esophageal diverticula, esophageal varices, esophageal cancer, and also some cervical spine disorders like atlantoaxial joint displacements or orthopedic conditions. Now the third echo is of course the stress echo. Here basically either you do two things: either you exercise the patient or give pharmacological agents. The principle is that when you increase the workload, then oxygen demand increases, and then demand supply mismatch will become more apparent. And once the demand supply mismatch happens, then part of the myocardium which is not receiving enough supply according to demand will start moving slowly. So there will be wall motion abnormality. So this is basically impaired thickening of the myocardium and impaired myocardial motion, which is the wall motion abnormality. So this will start appearing. And so if at rest there is no wall motion abnormality, but at exercise there is a wall motion abnormality, then this test is positive and it shows you that there is a ischemia. And depending on the territory of wall motion abnormality, you can predict which artery is affected. If it is the inferior territory, then you can say right coronary artery. If it is the septal territory, you can say left anterior descending. If it is a lateral wall, then you can say left circumflex artery. But as I said, exercise can be on treadmill, it could be supine bicycle, it could be upright bicycle, it could be hand grip, stair step. It could also be non-stress by drugs like dobutamine, dipyridamole, adenosine, pacing, and ergonovine. So these are some of the options. Common is dobutamine, and common is treadmill, or supine bicycle exercise is also common. Upright bicycle exercise is also common. Now, finally, the last part. It has been estimated that of all the cardiograms ordered, it was medicine people who were ordering the more cardiograms. So more than nearly 60% of them were ordered by medicine people. The most common reason for ordering echocardiogram was to rule out heart disease. More than one-fourth of the physicians uh, reported that echocardiographically significantly helped the patient. And nearly one-fourth of the people after doing echocardiography made some change to patient treatment. And more than two-thirds physicians considered echocardiogram essential in the management of adult patients. So I think you will understand the importance of echocardiogram and also how it is done. And now you would know the essentials of echocardiogram. Thank you so much.